My name is Val. I'm a nurse practitioner here at Light on Anxiety. And today I'll be presenting on mental health treatment for medically complex patients. So you can play the next one. So like Lisa said, we just wanted to introduce me so you guys know me a little bit more, find me more approachable, stop in, chat with me, send me emails if you need to. So I'm a PMHMP here out of the Wilmette office Monday through Thursday and Highland Park on Fridays. Some things about me. I'm a cat enthusiast. I love cats. So I put a picture of my cat on here. I couldn't present without it. She's a rescue cat from Texas. Her name is Sheba, and she is my favorite little thing. And then if I'm not at work, which I'm at work a lot, but if I'm not at work, my hobbies are thrifting, crafting, and decorating. So pretty much any grandma activity is my favorite. Currently, I'm not from Illinois, so if anyone has good thrift recommendations, please send me an email. I would love to know the good spots around here. And speaking of that, new to Illinois, just moved here from Wisconsin. I'm from Milwaukee, originally from Minnesota, went to undergrad in North Dakota. So I'm just doing a nice little tour of the Midwest. Apparently I do not like warm weather. So that's a little bit about me. We can go to the next slide. Okay, so my experience to get here. I took a little bit of a windy path. I'm a second-degree nurse. So I got my bachelor's of science at NDSU in psychology and biology. And originally I had the idea of going to grad school to become a clinical psychologist, and then kind of got lost along the way, followed kind of my passion for science and physical science. So I ended up getting my master's science of nursing at Marquette University in Milwaukee. And ended up in the ICU critical care. There, I really had a passion for anesthesiology, and thought I wanted to be a CRNA, which is similar to a nurse practitioner version of an anesthesiologist. But then while working with the patient population I was working with, interacting with the families, providing that emotional support that's so integral in critical care with life-threatening situations, I ended up kind of reigniting my passion for mental health care, taking care of the mind, not just the body, which then led me to going to Milwaukee School of Engineering to get my PMHMP. And so I have experience in inpatient psych, both pediatrics and adults. So adults is a lot of detoxing or active acute psychosis mania. And then children, a lot of behavioral issues, things like that. And then mental health addiction, recovery, PHP, IOP. And then as an RN working in the ICU, CVICU, and burn ICU. So that's kind of what led me to do this type of presentation. I feel like that's a unique experience that not a lot of mental health nurse practitioners have, that I do. So I kind of wanted to present on mental health care for patients that have received very intense physical medication in critical care settings. So we can go to the next page. So patient populations I would see and I would work with, both in the CVICU and the burn ICU. So CVICU stands for Cardiovascular Intensive Care Unit. I was at a level 1 trauma center at the time, which means that is the highest acuity, the sickest of the sick. The biggest emergencies are going to go to that level 1 trauma center, as well as in an intensive care unit. That's probably the sickest of the sick in a 3-hour radius of you. So a lot of patients I took care of were heart transplants and lung transplants. And these patients would be on our unit sometimes for a couple months. So they would be in our units for 2 months before getting their transplant, whether that's because they were acutely ill or because sometimes when you're in the hospital and you're in an intensive care unit, that will move you up on the transplant list. So there would be patients that would go from a fully working life to sit in their butt in a hospital bed and a recliner chair in a 20 by 20 room for 24 hours a day, seeing their family members. They'd stop by every so often. Some people live far away though, right? Trauma centers can be far from where people live if they live in greater Wisconsin or they're coming from Illinois. So there's a lot of loneliness, a lot of change in just our day-to-day habits, loss of autonomy. as well as taking care of ECMO patients. ECMO stands for extracorporeal membrane oxygenation. It's a machine that takes the job away from your heart and lungs, so we can give your heart and lungs a rest. Typically, it's used in very, very sick patients, patients with COVID. A lot of the times we're put on ECMO or ARDS, and basically it takes the blood out of one cannula, puts it in a machine, oxygenates it, and pumps it back in. These patients, this is normally a last-ditch effort. A lot of patients that go on ECMO are unable to sustain life after ECMO, as well as some patients have been on ECMO. I've taken care of patients that have been on ECMO for over a year, which means they're in a 20 by 20 room, in a bed, only being able to walk a couple times a day, because to walk with ECMO, you need a perfusionist, you need an RN, and you need an RT to help you, and a physical therapist. That's a lot of people to organize. You can't just get up out of bed anytime you please, the way you probably were functioning prior to being in the ICU. And then donor patients. So this is organ donating patients, whether that be from an anoxic brain injury, cardiac arrest, or donor after cardiac death. So typically a lot of the support is physical support for that patient, keeping them alive until the transplant team has arrived and are ready to harvest the organs, but also providing those families with the support that they need in that time. A lot of people that are organ donors, their death was very sudden. It wasn't, oh, we knew this was coming. It was cancer. We had 6 months to prepare. As well as taking care of shock calls. So that would be kind of, you know, when you see the helicopters flying above, very acutely ill patients that are either being taken from a small hospital with not a lot of resources and being sent to us, hopefully, so that we can escalate their care. A lot of times that is that emotional support for the families as coming to a bigger hospital, they have a lot of hope that we have all of these devices that might not exist that can provide their family member with continued care. And then in the burn ICU, I saw a lot of patients suffering from electrical, chemical, accelerant, thermal, radiation burns, and a majority of our patients were graft patients. So that's going to be split thickness skin grafts or full thickness skin grafts. Split thickness is where maybe they're going to take some healthy skin from the thigh, put it through a little machine, and then it stretches out. It has a little bit of a texture. It's probably what you guys envision if you envision a healed burn patient. And then full thickness is not making it any bigger, just taking it maybe from the back of the thigh and putting it, primarily we do those on the face to help with appearance. And that's a lot of what we were working with there in the burn ICU. We had a specialized burn psychologist that would help patients with their body image and just looking in the mirror for the first time. So in that unit, we have sheets that cover the mirrors until the patient decides that they're ready to take a look at themselves, because they can look so different from what they looked like 5 days prior. Taking care of suicide attempt patients, there was a lot of chemical or accelerant suicide attempts that we would see on the unit, where we'd take care of their burn care, as well as having the psych team on board to kind of help with their mental health status. And then frostbite patients, a lot of these patients required amputations, and there was a high comorbidity of being unmedicated, homeless schizophrenic patients. So we would do a lot of initiating of antipsychotics, oral psychotics, and then transitioning them to, if they were ready, to a long-acting injectable to kind of help with both their recovery, because if we're going to be in active psychosis and trying to relearn how to walk after having a bilateral below knee amputation, that's going to be kind of difficult. So they would be on the unit for quite a while, maybe a couple months as well. And then some drug overdose patients, whether that be accidental or purposeful, and then taking care of them. A lot of drug overdose patients, they'll be laying in unnatural positions for a very long time, resulting in compartment syndrome in your extremities, which means there's just a buildup of pressure. And unfortunately, the treatment for that is pretty traumatic. It's releasing pressure on both sides of the extremity with quite large incisions. So these patients, recovery is very painful. They need grafting as well to kind of close these incisions, and then just reorientation back into day-to-day life, whether we're going to help them get into a substance, PHP, IOP, or move forward in a different way. And then just something saw overall would be ICU delirium. Whether that be from the medications that we were giving those patients, or the fact that if you're acutely ill, there's probably a nurse coming into your room every 5 minutes, 24 hours a day. You're not going to get sleep. Your machines are beeping. And it really, firsthand experience showed me just how important a good night's sleep is, and that sleep in its own is medicine. So we can switch to the next slide. And so while these patients all seem very different and have very different, complex, unique physical needs, there are many similarities that overlap when considering their emotional needs. So some common psychological challenges of patients that have extended stays in the ICU are feelings of loss of autonomy, delirium and confusion, a sense of powerlessness, fear of permanent disability, or loss of self-sufficiency. A lot of these people, the way they're going to do their ADLs is so different from what they did before. They work a lot with occupational therapists to figure out, oh, I can't button my pants anymore because I just lost my thumbs and my 2 fingers. How do I now learn how to button my pants by myself? Because I don't want to have my partner button my pants every time I need to go to the bathroom. Feelings of frustration, helplessness, loss of identity. A lot of individuals aren't able to do their favorite hobbies anymore, whether that be knitting or playing soccer if they had a fasciotomy. Loneliness, like I said, there are visiting hours in the hospital. You don't always get to see people 24 hours a day, as well as if your family's located 3 hours away, you might see them a couple times a week versus seeing them every single day, every time after work. And the emotional burden of being dependent on others for basic needs. That can be really big for somebody that was a fully functioning lawyer that now is unable to bring a spoon to their mouth, as well as these patients have high rates of depression, anxiety, and then in some cases PTSD from their either accident, attempt, overdose, or just the stay itself in the ICU, which can lead to something called post-ICU syndrome, or PICS. And we can go to the next slide. And PICS can manifest in physical, cognitive, and psychological symptoms. And it can be post-traumatic stress disorder, where ICU survivors often report nightmares, flashbacks, and intense emotional reactions related to both the ICU experience or the experience prior: car crash, overdose, being set on fire at work, falling into a bonfire. The trauma of critical illness and the associated fear of dying or being unable to communicate may contribute to PTSD. There's a lot of patients that are on ventilators without sedation sometimes, which means that they have a tube down their trachea. They're unable to talk and communicate, but they're fully aware, and that can be quite distressing. While being off sedation is good for getting unextubated, but a lot of patients do have some trauma related to that. Anxiety and depression. Patients commonly experience high levels of anxiety and depression after their ICU stay, often related to the fear of reoccurrence of illness, physical disability, or cognitive decline. Sleep disturbances. Kind of talked a lot about how important sleep is. Patients may suffer from insomnia or disrupted sleep cycles because of their ICU stay. Sometimes they're not sleeping regularly for months on end. They might require some medications for that. And then social withdrawal and isolation. So some individuals that have ICU stays may avoid social interactions due to embarrassment about physical or cognitive impairments if they're not receiving the correct psychiatric care both during and after, as a result of their stay. We can go to the next slide. So, managing post-ICU syndrome. So we can start with cognitive rehabilitation, whether that be activities and exercises aimed at improving memory, attention and decision-making skills, as well as gradual reintroduction to cognitive tasks, starting with simple exercises and progressing over time. This can be started in the ICU and then continued after, as well as psychological support through CBT, as I think you guys are all aware, is really effective for addressing anxiety, depression, and PTSD, as well as some just trauma-focused therapies such as EMDR can help address those PTSD symptoms as well. Patients can also seek out support groups or peer counseling to make them feel less isolated and feel like they have a community. Medication-wise, these patients maybe will benefit from antidepressants for depression, anxiety, PTSD, whether that be SSRIs, SNRIs, possibly some anti-anxiety medication, maybe some sleep aids to help them sleep, whether that's going to be long-term or short-term. And then there are medications out there that can help with nightmares, flashbacks, things like that associated with PTSD. Family education and involvement is integral for managing post-ICU syndrome. So educating families about PICS and how to support recovery can improve outcomes for these individuals. And involvement in rehabilitation, therapy services, and daily routines can help both the patient and family navigate the recovery process. So we can go to the next page, which is where just ready for questions, as well as I just wanted to know if any of you have had the pleasure of possibly working with patients that have had ICU stays or extended stays in the hospital, where that's kind of their primary focus of treatment.
Hey, Valerie. So yeah, I'm coming from a behavioral health emergency department. So I would see a lot of patients kind of needing to go that route per se, but not necessarily in an ICU environment. That's really intense. And I bet you have a lot of stories and skills to share.
Yes, a lot of stories. I appreciate you sharing that.
Yeah.
Yeah, Dr. Kism.
Vala, maybe you will be getting to this a little bit, but what I think, besides being a wonderful prescriber, which we're so excited to have you on board, but this unique perspective of medical complexity, and sometimes when we're seeing clients where there may be a chronic health condition, or maybe they have concerns about their heart, and then we're trying to get them to engage in a panic protocol. So always we want to know that they're getting the right medical treatment on the outside, and then at the same time we're kind of proceeding with appropriate caution, both from the therapy side and from the prescribing side. So I know for me, knowing that you've kind of these complex health situations that people have, and they have mental health needs. So I guess I'm just wondering, since you've come to light on anxiety, if you kind of see this sweet spot where your perspective can, like, or when we should think like this would be a really good case for Val to help us with. Anything come to mind in the kind of cases that we have at Light on Anxiety?
I would say patients that are taking physical health medications. So whether that be someone that's a little bit older, that's on a couple of medications for their heart, blood pressure, diabetes medications, autoimmune medications, glucosteroids, things like that. Those medications can impact sorry, I got distracted by the beep. Those medications can impact other facets, right? So glucosteroids can kind of make our emotions feel more intense and things like that. And obviously, if you need that, you can't go down on that just because you're having that side effect, but maybe there's something that we can do to kind of help with our emotional regulation. So things like that.
It's very helpful. Thank you.
Yeah.
I have not seen a case like that intense. I have a client In his 50s, he suffered from a heart attack in November, and so now he's on whatever medications, that for his heart attack and then also for diabetes. And he, I guess, most of the stuff that we talk about is him just trying to go back to his like no, or like I guess, sorry, my brain is mashed potatoes right now. Just trying to like live his new normal life. His biggest gripe, so to say, is that he doesn't know what to eat. He lived 50 plus years of being able to eat, whatever he wants. And, I am not a doctor. I am not a dietitian. And so I'm like, yeah, that sucks clinically. But, and then I tell him, like, let's talk to your doctors. He has so many doctors, and he has a dietitian, and he's has the continuous glucose monitor. And so I don't know. I guess do you have any advice on like where to take a client like that? Because he doesn't want other medication. He just wants,
Yeah.
I don't know.
So was he seeing you prior to the heart attack?
No.
Okay. So he's seeking care probably for some new onset of anxiety due to the heart attack, maybe some health anxiety, things like that.
You would think that, but his anxiety is actually quite low. He's a very chill man. But I think definitely there's some health anxiety around, like, I don't want to eat something and then my blood sugar go up, or I don't want to, because he's also on some sort of diet where like he can't drink too much water. So it's like
Fluid
some of the stuff is
restriction
just
for
very
his
like
heart. Fluid restriction for his heart, I'm guessing.
I would assume so. Yeah.
Okay. Yeah, that's a lot of moving parts that he now has to be in charge of.
Mhm.
Okay. So is he trying to work through how to maybe handle that overload with you? Or what's his
Yeah.
primary? Okay.
Yeah.
Yeah, I would say that can be a lot when we have a dietitian, a cardiologist, an endocrinologist, all trying to be a part of our care. So maybe establishing ways to help him slow it down a little bit, whether that be writing things down, keeping a journal. Does he do that at all of his blood sugars?
He doesn't. He has like apps that are with the
The
glucose, and
Dexcom? Okay.
yeah.
Yeah, so I would
That's a
say
good
maybe
idea.
helping him create a digestible plan. So even just in that hour with you, being able to talk about his knowledge he has about these conditions, because you don't have any of that, right? You don't know what his fluid restriction is. You don't know if he's on metformin or if he's taking subcutaneous insulin, things like that. But he has that knowledge, and he can use that time with you to set himself up for success, to make like a little roadmap.
Mm.
Right. So maybe you could do that with him so he doesn't feel so overwhelmed, or like his thoughts are kind of just floating in the air about his diabetes and his heart health and what he can eat. I think maybe he would find that beneficial.
Valerie, I love what you're saying and how you're simplifying it, because I think that's part of what feels maybe overwhelming as a therapist, as a psychologist. Is it sometimes it feels like I need to know the fluid, or know that that's a thing, and then reminding myself it's really about just doing the work I would normally do, of helping to simplify if there's avoidance going on, all of the same things. And just sometimes when things feel more medically complicated, I think, my amygdala could take over a little bit, like, oh no, is this a heart thing? And so I think just sometimes like separating out, like, what are we still doing, even though someone is experiencing a medically complex situation, it's sort of calming myself down as a provider is really important. And I don't think it's just me or us, but I think sometimes people, it feels scary and they could get kind of like lost in the shuffle where that's more of a medical thing or that's more complex. So standard therapy wouldn't be helpful.
Mhm.
So I just sort of like the conversation around being available, in what ways we can be available for those with medically complex
Yeah.
profiles.
Mhm. And I mean, that's a lot of life stressors and change for him all at the same time. Like he has a device in his arm that just beeps at his phone 24 hours a day, telling him to check this, check that. So it's understandable that he's kind of feeling that way.
Mm-hmm.
Which, if anyone ever has, even if I'm not going to medication manage them, but if they have a question about something like that, you can send me an email. I'm more than happy to answer if I can. I'm not like the most physical med girly, but if I can, I'll try. Just show you guys or explain to you guys maybe what a session looks like for me, intake or follow-up. I can talk about both. So for an adult versus kids for intake, it's a little bit different and it's different from what you guys do. So for an adult, typically our intakes are going to be in person. And if the intake's not in person, we definitely want to see them in person in one of their first few follow-ups because we need their vitals and we need to put eyes on them and things like that. So adults, they get one intake session, preferably in person so that we can get their vitals. Children, they're going to get 2 intake sessions. The first one's going to be online and it's going to be with the parent to gather collateral information, hear the parent's concerns, separate from the kids' concerns. And then the second one is going to be in person with the parent and the kid. Depending on the kid's age or the kid's preference, sometimes I'll take them back alone to start with so they feel validated and heard by me first instead of just feeling like their parents in the room staring at them or interjecting. And so if I take them back, I'm going to do vitals and I'm going to explain to them why I'm doing vitals. So I always introduce myself to people as, hi, I'm Val, I'm a PMHMP here, or a psychiatric nurse practitioner. And then I'll ask if they're familiar with the role of a nurse practitioner. I find today, normally most people are familiar of what my scope of practice is, but some individuals hear nurse and they think nurse. Nurse practitioners, if someone says, no, I'm not familiar with that, I just give them a quick little education of like, I'm able to assess, diagnose, and prescribe medications for you today. And that is why I would need to take your vitals, because sometimes when we take medications, those medications can alter your vitals. So getting a good baseline set prior to starting medications can be beneficial to notice even the minor changes in you. I feel if people don't think about medication wise, they're like, why is this psych person taking my blood pressure? Like, what does that matter? So I always kind of explain to them that the medication management is why I'm getting their weight, their height, their blood pressure, their pulse. We get the weight and height, especially on kiddos, because they're growing, right? And some medications can suppress their appetites and change their growth rate. So those are important things for us to monitor, as well as blood pressure and heart rate. Some medications we prescribe, whether they be stimulants or SNRIs, can increase your blood pressure. Some medications that are anti-anxiety medications can decrease them. So we really want to make sure if we're on agents that are affecting our blood pressure or pulse, that we have a baseline, and that every so often we're checking it and or checking it at titration. So that's when we're going to go up or down on it. Some of these medications, if you take a beta blocker every single day for a year, and then your body gets used to that, a beta blocker slightly lowers your blood pressure and is a rate control agent. So manages how quickly or regularly your heart is beating. Things like propranolol. If you're taking that every single day for a year and then you just decide, I don't want it anymore, your body is acclimated to having that medication. And so you can get something called rebound hypertension, which means your body thought it was supposed to get its daily dose of propranolol. So it had acclimated to that. And now, because you're not having that medication, whoop, it goes through the roof. Typically with rebound hypertension, it goes away after a little bit, but those are just things that we want to monitor, especially with patients that sometimes our populations, they are medication non-compliant, right? They take their medications, they go, oh, I'm fixed, I feel great, I don't need this anymore, and they check it behind them. So just being able to have those baseline vitals is important. As well as then I kind of sit them down, and before I even meet them, I go through all of their intake paperwork, similarly to what you guys do. They have to fill out what, 11, 12, 13 forms. So I look at those and I look at the scales, the same scales that you guys are looking at and gathering every so often, as well as I look at an additional piece called the medical history form. So that one is just saying like allergies, who their primary care provider is, family health history. So not even just them, but parents, grandparents, family, just because with some medications, primarily stimulants, if a family has cardiovascular history, like, oh, their two uncles had heart attacks at the age of 30, that's when we're going to want to get cardiology involved, get a baseline EKG, and get a write-off that their heart is healthy enough to start these medications, right? Because yes, psychiatric care is important, but also your physical health is important as well. So it's this nice balance of risk benefit. So after kind of doing that, I will then sit them down and then I tell them, I looked through your paperwork, but we can only type so much. We can only get our message through so much online. I would love to hear in a brief sentence, like what led you here to medication management today? Some people do give me a nice brief sentence. Some people go, it all started back in 1990. And then sometimes I have to reel them back in a little bit. But so I want to hear their chief complaint, what led them here today, as well as I want to get a good idea on them. And that means their age, their gender, where do they work, what's their educational status, if they're in school, do they have a 504 IEP, what's their preferred name, preferred pronouns, things like that. And I write it in bold and I copy and paste that over so that every note I have, I just get that nice little blurb about them in my notes. And then I'll gather allergies. So medication allergies and food allergies. I just like to note both of those. And I like to keep it kind of high up on my list. And then I'll kind of go into past medical history. So what have you been diagnosed with in the past? Does that mean that I'm going to also say, yes, you have all of these things? No, I might disagree, but I like to have a baseline of what they've heard, what their knowledge is of possibly their current condition and things like that, as well as the history of presenting illness. So what do your symptoms look like? Is it every day? Is it a certain time of day? What does it feel like physically? How long have you been experiencing that? Things like that. Sometimes the patients are able to kind of just tell me the HPI all on their own. Sometimes I do need to kind of go down the DSM list if I'm assessing and just ask them questions, right? And then I will gather some also important information like history of suicide attempts, history of suicidal gestures, history of self-harm. History of behavioral higher levels of care, whether it be inpatient, IOP, PHP. It's good to know, have you had that level of care and when you had it? How, an individual that is just coming to me fresh from PHP is a lot different than, oh, I had PHP 2 years ago. And then history of therapy treatment and if they're currently in therapy and if they're in therapy here. So I like to write down all of the therapy that they've tried, right? So I want to know if they are an on-off, like, oh, I go for 6 months and then I stop and then I go. I like to ask, like, do you know what type of therapy? Was it CBT? Was it exposures? Was it talk therapy? And if they have had different types of therapy, I like to kind of hear, oh, I felt like this worked or I felt like this didn't. So I'll write a little blurb about that. And then history of behavioral health medication trials. So what medications have you tried before? and what were the dosages, how long were you on it, and why are you no longer on it. I specifically like to ask how long you were on it to see if it was an adequate trial, especially with like children and ADHD. If you took the medication for 2 days 3 years ago, that wasn't an adequate trial. It doesn't mean that that's a bad medication for you, and maybe we could revisit it. So that's always an important thing we like to gather, as well as behavioral health family history. So has mom been diagnosed with anything? Dad? Has anyone in the family committed or attempted suicide? Things like that, as well as I always like to fit in there if you feel comfortable sharing. So if mom says, I have anxiety, I'll ask if you feel comfortable sharing. Sometimes individuals with genetic links can respond in like ways to medication. So if you're on sertraline and you responded very well, typically if your child needs an SSRI, I would start with the medication you responded well to. Or sometimes they'll have a sibling that has gone through PHP, IOP, and is on a medication. So I always like to say, if you're comfortable, I never want to make someone feel like this provider's not my provider and now they're asking me what medications I'm on. But typically, most individuals feel comfortable sharing that, and they will share that information with me, which I find very helpful because it kind of just gives, is that medication going to be the right medication? We don't know, but it gives a little bit of like a direction for us to go in, as well as if the patient has ever had behavioral health testing. I like to have them, if they didn't get it at Light on Anxiety, I love to have them send it in, and I love to see when it was done, how long ago it was done, and what actually did they assess for, because they can all be like a little bit different from place to place. So I really like to have that physical copy, not just, oh yeah, and we were diagnosed with this. And so that is kind of the question portion. And then I'll go into more like medical health, and some medical health matters to me just because I talked a little bit about it. Our medications can impact things like seizures, cardiovascular health, blood pressure. So I like to ask, have you ever had an abnormal EKG? Have you had any, or the child, cardiac conditions, the family history of early cardiac or unexpected cardiac death, seizures? That's a really important one. A lot of our medications can lower the seizure threshold. So seizures is one that I always make sure to ask. Head trauma as well. And then asthma, as some of our medications are contraindicated with asthma. So those are the physical health things I like to assess for. And then I will kind of go into educational mode and kind of talk about like the current clinical picture, what the standard, like gold standard for what I have assessed for. So if I say, if I'm assessing that your daughter has anxiety, generalized anxiety, it's moderate at this point, that indicates CBT with an SSRI, and then talk to them a little bit about what that looks like, how the SSRI can benefit them, side effects, risks, the black box warning. It's a lot of information all at once, but I multiple times throughout will kind of ask, do you have any questions? As well as asking about current medications. Are they taking anything by mouth daily? Everything matters to me, whether it's melatonin or it's medication for their lupus. So I will ask about both over-the-counters, vitamin supplements I like to know about. There are a couple that really do not mix well with SSRIs. And then the previously tried psychotropic medications I also will kind of write down here. And then we kind of talk about the education. There's a good 15 minutes of parents asking quite a bit of questions, because starting a child on medications that's a big thing for a lot of parents, especially when they're younger. And then kind of talking that through. And then I typically will at intake sessions for adults, I'll possibly start medications because they're in person and I have a great clinical picture. But for the kiddos, because I haven't seen them at the intake session, then we'll schedule that second one in person. I'll let that parent kind of marinate with that clinical recommendation I gave them. So if they want to go to Dr. Google, which they always will, always will, at least now they can come to me prepared with questions with a little notebook instead of just emailing me 12 questions. If I don't even recommend that at the primary intake, and then I first recommend it at the in-person intake. And so that's kind of how the session goes. And then, if I'm ordering medications, I'll kind of instruct them, are you taking it with food? What time of day? You do need to be taking this every single day, or I'll explain how to take a PRN as needed, and how to notice when it's indicated and how often you can take it safely, and then order the medications and reschedule them. I always like to reschedule them in the same visit, just so that I make sure they don't get lost in the cracks. And that's my whole intake.
While we have Val here, does anyone happen to have a case in I had her during supervision today, so I had the opportunity to anytime Val's around, I actually always ask many of the questions about different cases that are medication questions around. So anyone want to take advantage of this?
It's not a case, but I do have a question regarding, you mentioned supplements can have different interactions. I guess, what are the most common ones that you find, just over-the-counter supplements that are having interactions with certain medications?
St. John's wort. That
Okay.
was a big one. If
Okay.
people hear them say that and they're on medication, immediately email us.
Okay. I'm gonna write that down. And I guess in terms of what the interaction is, what happens?
That one, I believe it increases the blood. What is the word? It increases toxicity. It blocks the induction of something, and then it increases it, so it gets toxic, and then they have serotonin syndrome. I'm sorry I said that in such an ugly way.
No, you're
But see,
fine.
that would be acute confusion, fever, nausea, and then they
Okay.
need to immediately go to the emergency room.
Okay. And that's if they're taking that, if they were to take that with an SSRI.
A lot, yes. And typically what I see is they're on an SSRI and then they are like, oh, I'm enjoying this. Let me look up other safe things I can do because it's over the counter. It's a vitamin. And then they
Mhm.
start taking it without even thinking about telling anybody because it's just a vitamin. It doesn't
Right.
matter. And then that's when it can cause interactions. So that's normally the progression I feel like I've seen it in.
Thank you. That helps a lot.
Dr. Mina?
I was wondering about how young clients are who are prescribed for SSRIs, because I'm just curious because I know have some clients who may have significant anxiety or selective mutism that are more around 6 or younger. I was just curious about the age.
I was going to say 6 is kind of that line. So typically anything under 6 there are some people that will prescribe. Do you have a parent with a 4-year-old that's looking for medication, or are you just kind of okay?
I was just curious.
I have another question. So I just had a client at 1 p.m. and he mentioned how he wants to start. He's working with Erica, but he's lowering, start tapering down from the 10 milligrams of Lexapro because he's noticing it's affecting his sex drive. And he was wondering, if there's anything he could do to kind of counteract what it's how it's affecting him, instead of completely going off of it.
Is he being treated for depression, anxiety, OCD?
Anxiety.
anxiety. Okay, so if it was depression, typically we'll switch them to Wellbutrin, but Wellbutrin does not work well for anxiety. He might benefit from like an SNRI, so Cymbalta or Effexor. So if he wants to change like medication class but still have anxiety support, those are known to have a lot less effect on libido, as well as, I mean, I just pulled up my SSRI chart for side effects. It'll do like +3 for like high occurrence and 0 for low, and all of the SSRIs are 3 or 4+. So Lexapro typically has one of the lower profiles for sexual dysfunction. So moving to another SSRI probably won't help him. So either lowering the dose and seeing if he has benefit on that lower dose, or maybe switching to an SNRI could help him out.
Thanks.
What class is Wellbutrin? It's not an SNRI. What is Wellbutrin?
No, it's an atypical. So it hits on norepinephrine and dopamine. So like sometimes it's considered that class, but it has that added dopamine.
More activated. Yeah.
Yeah.
Interesting.
And so typically it makes people anxious.
Yeah.
It's not the best. If you have a comorbidity of depression and anxiety, you can benefit from Wellbutrin. But if you just have anxiety, it's probably not going to make you feel very good.
That makes sense. All right. Well, thank you so much again. And thanks everyone for the great questions.